SJ is our patient, and his first problem is going to be his Class B infection. The assessment of disease is as follows. Patient has risk factors for MRSA, such as IV drug use, presence of an AV fistula for dialysis, chronic illness such as end-stage renal disease, type 1 diabetes mellitus, coronary artery disease, ischemic heart disease, and hypertension. Patient has a Class B infection as evidenced by pus around his AV fistula. Further evidence of bacteremia was verified by gram-positive cocci on catheter tip and exudate. Peripheral blood cultures 2 out of 2 from different sites used the Meldie-Toff method revealed a MRSA infection. The assessment of his drug therapy. Patient is currently receiving linezolide 600 milligrams IV twice a day. This is not appropriate, and the reason being is it's not empiric by ISDA guidelines. Patient has no pneumonia and also no endocarditis as verified by a TEE scan. Also, linezolide can worsen diabetes, and he could experience serotonin syndrome because of his tramadol. Our goal of therapy for this patient is to eradicate the infection and make sure no bacteria is present before a new port is inserted for dialysis. Our plan for this patient, if possible, remove the AV fistula for dialysis and place the patient on daptomycin 6 milligrams per kilogram every 48 hours via IV for 14 days. The rationale for this is due to his creatinine clearance. This dose is recommended, and daptomycin is considered first line per ISDA guidelines and is appropriate because our patient is allergic to vancomycin. The 14-day period is recommended if there is no endocarditis and no other complications. Patient's cultures seem to be diminishing and patient is afebrile. If the bacteremia improves but does not clear up, treatment should continue for 6 weeks or consider the use of an aminoglycoside for this patient. We would need to monitor his renal function and monitor for nephrotoxicity. And the aminoglycoside we could consider is gentamicin. Monitoring for this patient should include cultures to be taken 2 to 4 days after initiation of therapy. Monitor the patient's CPK levels once weekly or sooner if his renal function changes. Patient education. Patient should notify caregiver if muscle pain or weakness occur, which is associated with daptomycin. This would indicate peripheral neuropathy or myopathy. We should encourage the patient to seek help for his IV drug use and not share his belongings with other people once he's released, so as to not spread MRSA. We should encourage healthy eating and compliance with his medications and dialysis. For patient's hyperkalemia, which is the second problem, the assessment of disease, patient is hyperkalemic, as evidenced by his levels of 6.8 millimoles per liter. The normal limit should be between 3.5 to 5.1. He is also exhibiting abnormal EKG readings such as tall T waves and 140 for his QRS interval. Patient is exhibiting physical signs of fatigue and weakness. And along with the hyperkalemia, patient is dehydrated, so there is an electrolyte imbalance. His sodium is high and his glucose is elevated. His assessment of drug therapy. Patient was given albuterol 2.5 milligrams via nebulizer for 1 dose. This was not appropriate. Patient has ischemic heart disease and arrhythmias, and albuterol should be avoided in these kind of patients. Our goal of therapy for our patient is to correct his hyperkalemia, restore his cardiac function, his EKG to baseline as soon as possible. Our recommendation for this patient, plan 1, is to initiate calcium gluconate 10% IV over 2 to 3 minutes and repeat every 10 minutes until the EKG stabilizes. The rationale for this is this will stabilize the myocardium It, however, does not restore potassium levels. Therefore, our second plan is to facilitate movement of potassium from the extracellular space to the intracellular space, and we would do this by administering 10 units IV bolus of insulin. We would then monitor for hypoglycemia hourly. Monitoring the patient hourly for hypoglycemia and potassium level changes, and also his EKG. The patient education in this case, the patient should watch for constipation associated with calcium intake. He should watch for symptoms of hypoglycemia because of the insulin dosing, such as sweating, irritability, dizziness, and shakiness, confusion. Thank you very much.